This week on the BackTable Podcast.
We know that you can't just throw a bunch of materials up there and expect them to stick and have a great outcome. There is some precision required with repairing these defects. So if you go back to that image, certainly it looked like I could drill off part of the beak there in order to get some kind of superior and anterior clearance in order to be able to get some material over that defect. But I feel like medially we're pretty limited as well. And it's also a tough angle. It's not flat. How are my materials going to stick there? I would consider maybe doing a draft 3 at this point. I think on the other image, I saw that there is room to kind of take that bone anteriorly and inferiorly in order to get a really nice contoured repair. I think it's hard without being there in that situation, but I think I would probably continue to drill that beak and then maybe open up the other side and then really put like a really nice reconstruction that I can feel very confident in.
Yeah.
But maybe you made it happen on one side.
Well, we will find out very shortly. Welcome back, everyone. Now we're doing segment number 2 on our CSF leak management and comprehensive approach to CSF leaks. So again, I'm Satyan Sreenath. I'm a rhinologist at Indiana University, and we also have Sanjeet Rangarajan, who's a rhinologist and skull-base surgeon at Case Western Reserve University. And so we're going to take this as a little bit of stump the experts for Dr. Rangarajan, and because this will be a couple cases that we have from my clinical practice, going to really kind of piggyback off of what we already talked about for the approach and management of CSF leak and workup. And we're going to dive into a little bit of the weeds on how we approach these surgically, some surgical pearls and tips and tricks on endoscopic management. We'll go over a little bit about how we reconstruct some of these spontaneous leaks and encephalocele repairs. And then kind of go down a couple of different questions about each of these unique cases. From this perspective, this is kind of just, when I see patients with spontaneous CSF leaks and concern for encephalocele, this is in my head, my algorithm. When I'm thinking about my approach, we talked a lot about in part 1 of our podcast here about the history, physical exam findings, and a lot of the imaging workup. And so these are the key points. And now we'll kind of dive into the patients. And so Dr. Rangarajan, so this is a 48-year-old female. So she was presenting with 2 years of progressive headaches, sinus infections, nasal drainage. She thought that she had an episode of meningitis. This was a couple years back when she was living in a different state. They told her it was viral at the time. She got treated, didn't really have any other details. She had alternating thick and thin drainage, seemed to be predominant on one side, but couldn't really be sure. Nasal endoscopy wasn't really revealing. Ultimately, her local ENT took her for a left-sided limited sinus surgery, just some sinus disease in the ethmoid cavity, and kind of for an exploration. And this is what they found. And so we'll kind of go through this CT scan, but take me through a little bit of what you're seeing here.
Yeah, so on the left side of the screen, there's a right-sided septal deviation. There's some kind of scattered mucosal thickening, and then it looks like we've stopped at the kind of key image. We're kind of high in the ethmoid cavity. There's a pacified cell, and then I think if we go back a little bit, we would see kind of adjacent, I think it was to the lateral lamella, that it looked like there was maybe a small bony defect with some adjacent opacification there. So a little concerning for skull-base pathology, CSF leak on the left side. I don't know. Same thing on the sagittal image you're seeing, maybe a little bit better. There was a slice there that where there seems to be a bony defect with a small, pretty small area of opacification without a lot of other sinus disease.
Yeah, and I've kind of just superimposed some of those images, right? So that kind of key image that we're seeing here is that on that lateral left side, there seems to be developing what's potentially an encephalocele versus just a contained cell. We talked a lot about kind of the diagnostic tests in this situation. Besides obtaining a beta-2, which was actually positive in this patient, anything else you do diagnostically, any reason for any other workup, or do you think this is, at this point, enough clinical suspicion with a positive beta-2 that you would plan for a surgical intervention?
I think in this patient, these are the preoperative images, I'm assuming, before the surgeon takes them for a limited bus. Yeah. So I think, we're obviously becoming concerned for a spontaneous CSF leak on the left side, presumably adjacent to that, opacified ethmoid cell there. You do have CT images here, which I think is, certainly a crucial part of the workup. In part 1, we talked about the utility of utilizing nasal endoscopy, in terms of surgical planning, identifying of reconstructive options, et cetera. So I certainly think, nasal endoscopy, CT scan. I think when we think about the global management of these patients too, I think we'll get to it later, but, I think certainly there are a few of our subspecialty partners, certainly ophthalmology, that may be worthwhile to involve, before going to the operating room for a repair.
Yeah, I think those are all excellent points. And then as far as kind of, from the preoperative planning, the last step we talked a lot about in part one, the lumbar drain placement and utility. This is a patient actually, looking back through all of her old records, she had actually had a spinal tap at some point, I think probably when she had that episode of meningitis that actually showed an opening pressure of 35 millimeters of mercury. And so pretty elevated intracranial pressure at that time, at least. Would this be a patient that you consider lumbar drain placement preoperatively from both a therapeutic or diagnostic perspective?
So the opening pressure was taken when the patient actively had meningitis?
The history is a little bit sparse, but going back in the records, that's where I think only pressure noted.
Presumably this is a patient with high intracranial pressure, IAH. And I think from our previous discussion, I think I certainly understand the reasoning for utilizing a lumbar drain to reduce their pressure in the perioperative period to improve the chances of success for the repair. With that said, I think it is certainly part of the overall management and part of the success of this patient longitudinally for us to manage that pressure. But I actually still would not utilize a lumbar drain for the immediate repair, again, just because of my anecdotal experience. And again, this is getting into some of the controversial aspects of management. And I think, we can definitely go back and forth on that. I tend to think that the technique and how you perform the repair has, much more to do with, how successful you are than the pressure. But, let's say you repair and you get through that repair and she heals well, there's nothing to say that they're not going to start leaking from another location, et cetera, those types of things. So I understand what you're getting at. You're asking me honestly. I'm answering honestly, but I think the audience and the listeners can hopefully hear both sides and make their decision.
So that's a great point, and I am valid, and I will respectfully disagree actually with you in this scenario. So, and I will actually show you why. And so to the keen observer, actually on this CT scan, if you'll actually look, I don't know if there's cursors coming through, but on the contralateral side, and this is actually picked up by our neuroradiologist, there is a developing encephalocele. And so there's actually involving the attachment of the superior turbinate at the skull base. So this is a patient who may have a bilateral encephalocele and active CSF leak. And so in this situation, this was actually a patient that I opted to utilize a lumbar drain in this case, predominantly for the reason that I wanted to identify as there truly a bilateral CSF leak.
Okay. Yeah.
And in this situation, it was fairly obvious on the left side, and we'll kind of go through the surgical video, but that was the actual reason, because I was actually wanted to know diagnostically, is this patient leaking bilaterally or not? Because that would significantly impact my reconstruction plans. So we'll go through the surgical video here. So again, this is endoscopic reduction of a left lateral superior ethmoid skull base encephalocele. So you can kind of see here, this is sinonasal exposure. We do kind of a left-sided sinonasal fess type approach. We're exposing the ethmoid skull base around the fovea. Here, we're identifying the encephalocele itself. We're removing some of the bony partitions adjacent to it. We see that perfectly green hue, which is coming through from the fluorescein injection from the dye. This is actually use of an endoscopic coblator, which works perfectly to actually ablate the tissue and cauterize adjacently at the same time. We're now removing some of the extradural tissue of the encephalocele, cauterizing the defect. The important part here is we're visualizing exactly where the actual bony and dural defect is. In this situation, we're able to control the leak actually with bipolar cautery. We're harvesting a free mucosal graft as an onlay. Perfect coverage. We've stripped all the mucosa in this region. We've ablated it either with stripping mucosa or using the coblator to ablate the mucosal area and allowing for a good reconstruction here. And so, from your perspective, anything you would have done differently from the reconstructive standpoint when you're approaching these situations, how do you approach the actual encephalocele? Because interestingly enough, in this patient, she was not actively leaking from the encephalocele at the time of surgery. And so are there any tips and tricks that you utilize? Like, I typically tend to utilize the coblator or some kind of bipolar technology to actually reduce the actual encephalocele itself while cauterizing, so that typically allows me to reduce it without creating a leak and get back to the defect itself for reconstructive purposes. Anything you do differently?
It's impeccable technique, Sat. And I don't think I would do a lot that was different in that situation. I think you hit on some of the key points with certainly you showed a very nice exposure there. I think it's important to get wide exposure, even though these bony defects tend to be small. it really helps us to get a really nice visualization of everywhere around that bony defect, as well as it's important to have, some exposed bone for, that nice sized free mucosal graft that you place down. You did a really nice job with stripping the mucosa from that area. I like to use, it's a concentric endoscopic suction bipolar. So very similar to a suction bovie in that it's malleable and very looks like a suction bovie, but it actually just coagulates between two metallic rings, and it's a bipolar, so it's safe for the skull base. And so I will shrink the encephalocele very similarly to how you did in the video. And then I love free mucosal grafts. Again, I think early in my practice I felt more pressure to use maybe vascularized flaps and much more robust methods of reconstruction. But I think, again, had really great success. Maybe I wasn't paying attention, but was there an intradural repair as well? Or was it just,
That's a great point, because I think in some of these cases, there was not actually a significant
active
leak,
repair, right?
It wasn't an active leak.
Yeah.
So in those situations, when you're trying to say different from a tumor surgery, where we're thinking about, getting a certain type of inlay reconstruction, dural reconstruction, secondarily then followed by an onlay reconstruction. I typically find that in some of these cases, the dura is very tight to the bone in the epidural space.
Hard to elevate.
So trying to actually get a true inlay in these cases is challenging. And so in this situation, I opted to put, a small piece of Duragen, Zurich repair as an onlay and then a secondary onlay. Is that necessary? Probably not. It's probably sufficient. There wasn't an active leak that developed once we were able to cauterize, and free mucosa worked great. Would you think about this differently in multi-layered reconstruction, given her history of an elevated pressure? Do you think that plays a different role?
Not necessarily. I mean, I think I would do exactly the same thing. Some type of, in this case, an intradural repair is not necessary because the dura is intact. She's not actively leaking, right? And so, although you have questions, where did that positive beta 2 come from, right? But no, I don't. I do these pretty much the same way. I'll use some type of, if it's possible, an intradural repair, then potentially maybe something between the dura and the bone. Like you mentioned, it can be hard to create that space. And so we do have at our disposal a lot of different types of off-the-shelf products that we can use for that part of the reconstruction. Some of those materials swell a lot. Some of them are, very easily malleable. Some are less, easily manipulated. So I don't think I would do anything differently in that case. And in spite of the fact that she was high pressure.
Yeah. Just to kind of go back to the point we made earlier, right? So this patient had a developing encephalocele that we could see from the right side. So her history was she only had a positive beta 2 from left-sided nasal drainage. And so she had an obvious encephalocele. Endoscopically, we didn't see any obvious, green hue. We didn't see obvious fluorescein. We didn't see any obvious leak on that right side. How do you approach these situations, right? When you're thinking about you're following this patient for a while, they can develop secondary sites of CSF leak. We just reconstructed an area where she was likely leaking from previously. Lo and behold, she might develop increased pressure. She might develop. And so do you have a strategy on how you surveil these patients long-term, right? Do you counsel them at the time of just like in your post-op period, you had concerning signs of a developing area of potential weakness on the right side? How do you really counsel patients on that?
Yeah, so I think it's really important that the first time you meet a patient that the leak is a symptom of a disease process, right? And I think that sometimes, just like with chronic rhinosinusitis with nasal polyposis, it's not just that there's these growths growing in your nose, it's part of an overall disease process. So getting them to understand that, increased pressure is the etiology of what's happening is really important so that they understand your reasoning for long-term follow-up. So, to answer your question, we talked about measuring opening pressures. And I think that for me, the timing to do that is after repair, at least 6 to, 8 weeks down the road, once your repair is assured that it's, healing properly and, they're no longer leaking. I think getting that opening pressure is really important to try to set the stage for what's coming next, right? Because in many of these patients, the pressure will be high and we need to find a way to manage that. I think there's a lot of excitement around, GLP-1 inhibitors and ways to help with weight loss. There's certainly a role for acetazolamide. There's some, different papers in our literature that kind of look at that. But I think getting them plugged in, you have a couple of suggestions here. Neuroophthalmology, I think, is one that I really manage these patients with closely to measure for papilledema. You've mentioned neurology. I do think if there's some, ongoing management of other medications, acetazolamide, et cetera, maybe involve them. But certainly ophthalmology is who I would bring in at this phase.
Yeah.
And in terms of surveillance of the post-op defect and looking at the reconstruction, I like to CT these people at about 6 months and then maybe a year thereafter, just to, catch any kind of, early mucosal formation, repair failure, et cetera, like that. I mean, beyond that, I try to follow these patients clinically. Do you have thoughts on that? Because actually, I've never really had a good response to like when you should image these patients afterwards, or if you should.
Yeah, no, that's a good point. No, at least in my practice, I'll monitor them clinically, right, with the tool that we have with endoscopy in office and with the prior surgery, you're going to be able to visualize everything pretty clearly, and I'll just go off of clinical signs at that point, right, unless there is something concerning to me, like they're developing, changes, more drainage, or contralateral side, or they develop hearing loss, and you look in their ear and they have a middle ear effusion, right, and then you get a CT of their temporal bones, and it shows a tegment defect.
Sure.
So there are other potentials here that can develop, and I think your basic physical exam and your clinical endoscopy should be sufficient before necessarily at least getting imaging. At least in my practice, that's been the case. But I don't think there's one right answer, right? I think the important part here is really having patients, just like you have patients with chronic sinusitis, right? This is a disease process that is presented with the sign and symptom of a CSF leak. And so, what I tell patients is, at least if you have a good relationship with your neuro-ophthalmologist or somebody who's helping co-manage the medical comorbidities, the surgeon becomes the technician, right? And you're addressing the repair. And, if you are comfortable in your practice in prescribing Diamox, adjusting dosage, managing that medication long-term, there are other known side effects. You can develop side effects to them. You can develop hypokalemia with them. And so routine blood work with it is important if you are primarily managing it. And, you as well as I do in a busy surgical practice, this can be challenging to manage a lot of the medical comorbidities.
So, absent so far, we haven't mentioned our neurosurgery colleagues in the discussion today.
That's interesting. You brought that up because we'll see our neurosurgical colleagues potentially in action in this case. But this is just allergies, right? It's just nasal congestion, stuffy nose. That can't be anything else, right? I mean, this is just allergies. 66-year-old female. She presented with nasal drainage, nasal congestion. Really, she just can't breathe, and she just has headaches. 10 times out of 10, that's probably polyps, I would imagine. But she's tried nasal steroids. She's tried cocktail medications for migraines, and she didn't really have much improvement. It's been going on for over a year. But she got some antibiotics and steroids, and she felt better because steroids are fixing everything, as we all know. And ultimately, her PCP had a great idea, obtained a CT scan, and then immediately sent her to the ER. And we'll go through why that is. And so, this is a pre-op workup. The patient, this is a MRI that was gotten after the CT scan. We'll kind of go through this CT, but in its time, so this is showing a large nasal mass potentially, but a pretty large, sizable skull-base defect at the sphenoid planum, extending back to the right orbital apex. There was a pretty immediate worry that this patient had some kind of tumor. And so we were missing something, had this been going on for over a year, it was causing worsening signs and symptoms. And so in the ER, the patient actually got this MRI scan. And so we'll kind of go through this imaging here, but it shows a pretty large pedunculated mass that is extending towards that right sphenoid planum defect. There's potential significant vasculature in proximity to this area. And looking at these images, looking at this scan, where's your head going now? Are you thinking, is this a tumor that basically got underdiagnosed and been progressive over the last year? Is this something that you would consider a biopsy in office, right? If you're thinking about this as a mass or a lesion. Without the MRI, with the CT scan, how would you essentially approach that? What are your thoughts when you're seeing this patient, that's coming to see you in clinic? You see just a mass on nasal endoscopy.
Yeah, so certainly, I think you have to consider neoplasm on the differential here. I mean, even pituitary tumors can expand well into the sinuses in a very late stage. Don't necessarily present quite like this, but I think certainly neoplasms are on the differential. I think mucosales, certainly encephalocele, which is what we're talking about today. I think that the board answer is that you typically shouldn't biopsy intranasal masses, unless you have imaging. In this case, we do have imaging, and now we're seeing the patients in the office. I'll say that encephaloceles, they typically look different from tumors. And so, I think, they can be pulsatile. I mean, I think, practically speaking, you're getting some clues when you're seeing this patient in the office. And so, if I'm pretty suspicious of an encephalocele, no, I will not biopsy it in the office. Sinonasal tumors, we can talk about that a different day, about whether or not we should be biopsying them in the office.
Yeah.
I do biopsy them in the office.
Yeah.
But
still put that to rest.
But I think in this case, I'm pretty concerned about an encephalocele. No, I would not biopsy it in the office. And item number 3 on your, I think I would be talking to my neurosurgery colleagues at this point about this case, primarily just because of the location. You mentioned the prominent vasculature, adjacent to the sella, and I didn't see, but, I don't know, potentially the clivus, the planum. There's a lot of areas that are involved there where there could be potential hazards. And I think, having 4 hands instead of 2 in this case would potentially be helpful.
Yeah. I totally agree with all those points. And in this situation, I did involve my neurosurgical colleague for the reasons you mentioned, right? As two heads, as I tell patients all the time when patients see me pre-op for any skull-based surgery or combined surgery, 2 heads are better than 1, 4 hands are better than 2. And so when we think about the approach in this scenario, this is a patient that you consider the other neurosurgical complications, right? There is significant vasculature that we know exists on the ventral surface of the frontal lobe. There can be frontotemporal branches. There can be, aberrant branches coming off the internal carotid circulation, especially back at the orbital apex. These are areas where neurosurgical complications are real. And so this is not, even though the base pathophysiology is an encephalocele and the CSF leak that we reconstruct and primarily do on our own as ENT skull-based surgeons, this is a different beast. And so we'll kind of go through the surgical video here initially on the exposure. So this was a large encephalocele with an associated CSF leak. We can see kind of a large sinonasal mass essentially extending towards a defect at the right sphenoid planum, extending back to the orbital apex. There's a bony areas, very thinning in the olfactory groove and olfactory recess with an obvious bony defect to the right sphenoid planum. So in this scenario, I actually opted for a vascularized reconstruction for a couple of reasons. The biggest reason was mostly the size of the bony defect originally, and then this patient actually did have an elevated intracranial pressure, and so a couple of those reasons maybe opt for a vascularized reconstruction. So we did a bilateral kind of endoscopic craniofacial approach. Here we are kind of drilling off the sphenoid rostrum. We're exposing areas posteriorly, and we obviously see here a pretty large mass extending from the right sphenoid planum. The important part here is you're really delineating all the boundaries here, right? And so you're seeing at this point, you have a large air segment of essentially brain tissue that's herniated into this defect, a very large meningoencephalocele. We see there's active CSF leak with the obvious fluorescein drainage. With these areas, you kind of end up sometimes pivoting in these areas, but I'd like to think about what are your intraoperative considerations here? We have this large mass, essentially is a herniating brain parenchyma into the sinonasal cavity in the sphenoid. There's multifocal dehiscence. How do you approach this? I opted to do a nasoseptal flap, mostly for just coverage. Are there any other things that you would be thinking of? Are there any other considerations from reconstruction you want to be planning ahead? What are your thoughts there?
Yeah, this is a great case. And again, fantastic technique and good exposure. You guys did a really nice job kind of, making sure that you're seeing everything before, starting to think about reconstruction. I think certainly a challenging case. I think, what was most concerning to me in the preoperative imaging was not the size of the mass, it was the size of the bony defect and, and its location. And I think, given that this is very different from the first case, now you have active CSF leakage, you have, like you mentioned, large amounts of brain herniating. I think nasoseptal flap is the way to go here. It's 100% what I would do. And I think that you would, again, employ a multi-layer closure with several of the other, materials that we talked about before. I actually also think a lumbar drain would be useful here. Again, given the size of the defect, the multifocal dehiscence, I think, this is a load the boat situation. And, so I definitely agree with the utilization of a lumbar drain in this, situation.
And when you're handling this brain tissue, right? Is this functioning brain tissue? Is this, are you resecting brain in these scenarios? These are questions patients ask all the time that they'll come in and it's like, am I going to be different? You're involving a neurosurgeon, might heightens their concerns and suspicions. How are you approaching that amount of herniated tissue?
Yeah, I tell them it's mostly just repressed childhood trauma that we're getting rid of. But no, I tell them it's essentially non-functioning central nervous system tissue. They won't have a difference in function or cognition after surgery. And we do what we need in order to reduce that tissue back to the level of the bony defect. That's as far as we need to go, I think, in those cases. But no, I agree. Patients definitely, have that question. And even if they don't ask that question, it's important to kind of address that up front, and so they don't have those fears afterwards.
Yeah, I think this is a real concern also in patients, and I think we joke about the role from the neurosurgeon here, but I mean the risks in these scenarios, and ultimately at this point, this is a skull-based team that's addressing this kind of defect, this kind of sinonasal herniation of brain tissue in the encephalocele, and so having all the pieces of your team is very important in managing this effectively. And then these are patients, I totally agree with you. This is non-functional tissue at this point. Essentially, I think about like a hernia, essentially that's come through. But in these situations, a lot of it you are partially resecting, but you are also partially reducing. And so that's where I think my go-to surgical instrument in these cases is the endoscopic coblator. I think it has the functional capacity for bipolar reduction of the tissue, but also sometimes tissue ablation. The other end, they're malleable endoscopic bipolars, like the Aquamanus bipolar, which has been very helpful in some of these scenarios for reducing tissue and for cauterization as you're reducing it. And so we'll kind of go through some of that here. And so again, to your point, we really wanted to see everything very broadly before we attacked the primary mass. And so we're elevating the tissue. This is where we're elevating it and partially reducing it. We're bipolaring that tissue very effectively because we don't really know if there's vasculature that's herniated along with the parenchyma. And then really getting back to that bony defect. So the coblator works really nicely to really just kind of essentially elevate and reduce that brain tissue that's herniated through the defect. Now we're seeing the actual bony defect and we're seeing the dural defect. And so it's important to see kind of 360 degrees about all of these areas in order to kind of think about your reconstruction. Here, we actually opted to do a dual layer of biodesign, essentially a synthetic dural reconstruction as an inlay and an onlay. I think you might be familiar as I am with some other options such as the button graft repair or fasciolata. Would you speak to anything you do differently from the inlay perspective? I think you and I are both on the same page as far as the nasoseptal flap for vascularized coverage and reconstruction. Anything you do, you would manage the dural reconstruction differently in your experience?
No, I think the product that you mentioned is really good for the reason of it acts a lot like fasciolata, which I think is another great material. Nothing wrong with harvesting fasciolata, but I think having something that's going to be malleable and kind of adapt itself, to that location, something that doesn't swell a lot and nothing that's, particularly rigid is what you really need to have. If any of my Jefferson colleagues are listening, I think the bilayer button graft is an exceptional technique, and you can do that with off-the-shelf products as well. It doesn't necessarily have to always be fasciolata. And I think that, the advantage to utilizing a button graft is, you have an inlay and an onlay that are both combating migration for each leaflet of the graft. And so no, I think we would have prepared this very similarly and then followed it up with the nasoseptal flap.
I'm totally agree with you. And I think these are some of the locations where, the button graft, I think, works miraculously. I think you and I have very similar training backgrounds on utilization and the ability to have a dual layer closure, an inlay and an onlay and an epidural space sometimes to prevent migration. Fortunately, the scenarios, the brain seems to help us, right? Where it actually kind of closes off that space to some degree versus where you're, communicating with the ventricle or high flow CSF leak. These cases tend to be a little bit different in that scenario, but we'll kind of in the interest of time keep going. So, we haven't gotten to anything where I've really struggled yet. This is, routine case, experienced endoscopic skull-based surgeons, but now I want to struggle. And now I want to get your opinion because I don't think I actually did this case in the best possible way. So
it's hard to imagine you struggling, Sat.
I know. It's a challenge, but we all have our graces where we struggle. But so this is a patient who'd come, had a runny nose started after an MBC that he had about a couple of years ago. So, different patient population. This is a 47-year-old male, non-obese patient, had intermittent nasal drainage, headache, but then everything seemed to worsen after this car accident that he had a couple of years ago. Interestingly enough, this patient had sinus surgery almost 10 years ago. He had improved symptoms, didn't really have sinus infections, felt great after that. And the nasal endoscopy didn't reveal any obvious encephalocele, but there was just pulsatile movement that I could see within the anterior ethmoid region and the frontal outflow tract. Something that you can sometimes see with mucoceles, you can see with, obstructed outflow tract drainage, but no drainage. Valsalva may have increased some of the drainage, but nothing to easily collect until he actually went home and was actually at the gym. And so he was just basically lifting weights and then was able to collect fluid after a particularly heavy set, and then that was positive for beta 2. So we'll go through the imaging here, but this is a skull-based defect really emanating from almost at the juncture of the fovea ethmoidalis and the posterior table of the frontal sinus, and very high location and sort of midline. As you can kind of see here on the sagittal scan, we really see that defect kind of high in midline, but a challenging spot because when we think about endoscopically, I mean, this is an area where we're seeing kind of that that bony defect extending into that space. And so when you approach this, when you think about this location, what is your surgical corridor here? Because I really was struggling on how do I approach this. This is a patient who needs, a transorbital endoscopic approach. This is a patient who needs a trephine approach, just be given the location, or is this something that with either a draft 3, I could get to this defect pretty effectively, or, with some push and heart and some luck, could I get there uninostril? What are your thoughts here when you're seeing a defect like this?
So I agree with you. I think this is a difficult location because of how midline and high it is. And again, sometimes you see, things along the lateral lamella and just that angle, and kind of like we mentioned before, the dura tends to be like super adherent and tight to the bone. So it's hard to, put materials in that area. It's hard to see in this area. I'm going to stretch and say that I would talk very comprehensively with the patient about all of the things that you mentioned and the possibilities. Obviously we go in with the goal of repairing this. It's positive beta 2. We've done our homework. I actually would try uninostril, a direct approach first. I'm just going to say that's what I would try first, but I would be ready to utilize any of the other methods that you mentioned. I'm very curious to see what happens with this case. And
this is why we're friends, because, you think great minds think alike, because I wanted to be the minimally invasive guy. I didn't want to give this guy a scar, young guy in his 40s. And so that's the way I opted as well. But I think to your point, because before we go over the case, heavy counseling with the patient, consent for possible orbital incision, possible Lynch incision, possible trephine incision. When you think about possible open approaches, having preparation for all these potential aspects, potentially having to address the contralateral side, if we're having to do a bilateral drill out just for access and exposure. But being young and motivated, just like you are, Dr. Satyan Rangarajan, we wanted a uninostril approach. And so, this is kind of a unilateral approach for the frontal encephalocele, and we're going to go through this. So this is a single-sided exposure. A lot of the sinus surgery had been done previously, pretty good sinus surgery done previously a while back. We're now starting to see it's actually that pulsatile movement is actually a frontal encephalocele that was involving the outflow tract. Again, using kind of my handy-dandy endoscopic coblator for reduction of the actual encephalocele back to the defect. This is a situation where there's multiple tools. So this is that malleable endoscopic irrigating bipolar I mentioned. That was actually helpful to reduce the bony defect. We're now seeing into the frontal outflow tract. And so this is a part here where we're actually elevating a lot of that extradural tissue that's essentially herniated so that you can visualize the actual bony and dural defect. And, this was the particular challenge here. And this is not as very obvious on the CT scan, but what we're seeing here, what are your thoughts at this point? So I think I've partially identified the defect. We have a nasal beak that's really pushing onto the upper part of the encephalocele, upper part of the dural defect and bony defect. We're still a single nostril, but do we think at this point, can we get a good reconstruction? Can we get a tight repair? Do we think that we've completely visualized this defect? And where would you essentially go from here? And so we'll kind of go back to here. We're seeing the intraoperative considerations. What would be your point at this point? Do you think?
It's a great question. What kind of scope were you using there? I'm just curious. Were you using 0, 30?
That was a 30-degree scope.
30-degree scope. Yeah. So I think, at that point in the case, you would be getting a sense of how difficult it is to instrument the area, like in general. And so I think, at least I tend to get a gestalt even as I'm kind of approaching that time of reconstruction as to how difficult this is, because we know that you can't just throw a bunch of materials up there and expect them to stick and have a great outcome, right? There is some precision required with repairing these defects. So if you go back to that image, I think, certainly it looked like I could drill off part of the beak there, in order to get some kind of superior and anterior clearance in order to be able to get some material over that defect. But to your point, I feel like medially we're pretty limited as well. And it's also a tough angle. It's a little bit at an angle. It's not flat. How are my materials going to stick there? I would consider maybe doing a draft 3 at this point. I mean, I think on the other image, I saw that there is room to kind of take that bone anteriorly and inferiorly in order to get a really nice kind of contoured repair. I think it's hard without being there in that situation, but I think I would probably continue to drill that beak and then maybe open up the other side and then really put like a really nice reconstruction that I can feel very confident in. Yeah. But maybe you made it happen on one side.
Well, we will find out very shortly. So the one part I guess I'll draw to your attention here is and an option that I actually thought instead of doing a full draft 3 bilateral drill out, kind of like an extended hybrid unilateral drill out draft 2B and leading into a draft 3. My only real reasoning there is if you see kind of that defect, the bony defect is along that fovea ethmoidalis extending onto the posterior table, but the inner sinus septum is intact. And so I kind of felt that if I leave that bone intact, it makes my bony reconstruction a little bit, at least it leaves a better bolster to essentially
get support it there.
Exactly.
Yeah.
And so otherwise you draft 3, you're probably going to get better exposure, wider exposure, and you'll be able to see everything a little better. But then you're thinking that your bony reconstruction needs to be more along the posterior table and maybe a little higher, rather than the situation where I can use that kind of upper part of the inner sinus septum to actually lay an inlay in. And so that's kind of where I cheated towards. So this is a unilateral drill out. This is a single nostril approach. And so I have not opened up the contralateral side yet. I've taken down more of the beak as I continue to work that beak and kind of still leave that bony strut. Now we're seeing the top edge of the dural defect. We're seeing that whole area. We're seeing the frontal sinus outflow tract exposed. I feel much better in this scenario about doing my precision inlay, as you'd mentioned, using a biodesign as that inlay. This is a unique area where I was able to use curved instrumentation to actually really inlay that biodesign in the epidural space. Now I'm using a free mucosal graft to kind of lay as onlay reconstruction using fibrillar Surgicel. We used to use at Cleveland Clinic something called the cigars or cigarellos that was coined by my fellowship mentor that actually helps to bolster that reconstruction. Here we place dural sealant. And this is actually a great trick that I learned in training and actually has been published now. I think it might actually be Dr. Abi Hakamu published on the use of a Propel stent implant that can actually maintain the patency of your frontal outflow tract while also putting a little pressure actually on that area.
Yeah, I love that technique because maintaining the patency of that frontal sinus is what's going to prevent you from going back there surgically. And then I agree, it's going to put some lateral pressure on your reconstruction there. So yeah, well done. I like it.
So let's pause the brakes on if I was truly well done or not. But interestingly enough, this patient did amazingly for about 6 months. And he came back to clinic and started to say, I'm starting to see some symptoms again. I'm starting to see some unilateral nasal drainage. And, I looked in, didn't see anything obvious. I wasn't able to reproduce anything in clinic just like last time. But unfortunately, actually, the patient came back in about 6 months post-op and had recurrent nasal drainage, which was actually beta 2 positive. Now, this was a little bit tricky because, this patient, he's essentially a farmer. And so, this was coming up to his kind of high crop season. He did not want to be down for surgery. And he didn't really have a lot of the exact same symptoms. He wasn't having continuous rhinorrhea. The drainage, I know we mentioned earlier about the salty and metallic taste, but he said that the taste seemed to be different. I don't know if he was just trying to make something up to me to avoid another surgery. But interestingly enough, for about 3 months, we kind of hemmed and hawed whether or not to go back to the operating room. He really didn't want to go back. And eventually, he stopped leaking. I saw him back for about a year following this. And so where would you approach that situation at that 6-month period? Would you kind of push them in a certain direction about talking about, the risks? We talk about why do we do surgery in these cases, right? Do we do it as a reason that we're, the risk for meningitis? Is it the risk for sinus infection leading to intracranial infections? But how would you approach that situation where I got lucky in this scenario? For whatever reason it might be, he seemed to spontaneously seal. But how would you approach that scenario at that 6-month period?
So, looking at your approach and looking at the video as to how you repaired this, surveillance should be very easy in that area. And so it is a bit puzzling to look in and not see anything. However, we do know that there are people who intermittently leak for whatever reason, and they start and they stop and they start and they stop. I think I would have gotten imaging at that 6-month period when he first initially, presented, regardless of whether, remember, I think I mentioned I usually get it at about 6 months anyways. And so I would be certainly looking to see, we talked about one patient earlier that there was a developing issue on the contralateral side. And so looking for other locations. However, we didn't really talk extensively about the timing of these repairs, but, I don't know that I would rush this patient off to the operating room until I at least had more information. But I think at this point I would get imaging and certainly try to figure out what's happening here.
Yeah, and I kind of struggled with this decision because, this is a patient that, I did end up getting imaging. It truthfully didn't really show much difference. There wasn't a new defect. There wasn't, and we had a positive beta 2. So we essentially had a patient who had active drainage, positive beta 2, and no new defect. So for all intents and purposes, this is coming from the same area, or basically a recurrent leak. But I think this all goes back to the crux of the point that you mentioned here is, we didn't really talk about the timing of surgery and the reasoning for surgery, right? So I think, and we can spend a couple minutes here discussing that because, the reality is the reason we do these surgeries, the reason we do this is essentially the potential risk for infection, the potential risk for meningitis. But the data would suggest, this isn't a patient that we rush to the operating room, just as you mentioned, right? You kind of want them to declare themselves, but is there a time that you say when you see a patient, either in this type of scenario or outpatient setting, that you schedule surgery? Is there a time period that you think is too long to wait to be able to go back to the operating room? Or do you have these patients set up to have surgery the next week or two?
Probably not in the next week or two. I think this is, where we love to talk about shared decision making, but I think that is kind of what we have to do here. Yeah, the reason we operate it typically is that we need to separate the brain contents from sinus contents. And so we are trying to avoid meningitis and other intracranial complications. And so for the reasons to do something now are the same as the reason to do something before, except for in this case, we have maybe a little bit less information and the patient has already had an operation. So I think in terms of shared decision-making with the patient, surgical expiration in this case probably means taking the patient to the operating room, challenging them, right? Valsalvas, maybe a lumbar drain with intrathecal fluorescein, and trying to spur on a leak that we can see. If you see something coming from that area, which is, again, probably likely in this situation, typically it means taking down your entire reconstruction and redoing the whole thing again, right? And maybe altering your strategy or maybe saying, I got unlucky this time. But that's what surgery, I think, is really kind of involving here. On the flip side, we do have patients who, for instance, traumatic CSF leaks. Again, I know it's a different etiology here and a different kind of pathogenesis, but, we know that those spontaneously heal up. And many of them never come back again. So, is there a role potentially for observation? Is there a role for maybe, a trial of Diamox for, several months and then a trial off? This is where it gets really controversial, right? Because I think, there's certainly some people who would be saying, there's a leak, you need to go in and fix it, okay? On the flip side, I think you bring up good points. So I don't know. Do you have different thoughts?
No, I have the exact same controversy in my head that you mentioned here. So I think in this scenario, I just, happened to get lucky. I think patient essentially maybe was a bit stubborn for good reason in this scenario. And, he is now 3 years out and he's not had a recurrent leak. And so it's interesting because I think we oftentimes think the risk outweigh the benefit of waiting. But in this scenario, close observation, following up, essentially spontaneously sealed. And so without needing a secondary operation. All right, last case. I saved the best for last, Dr. Rangarajan. So both sides, nasal drainage. That's probably non-allergic rhinitis, right? Probably motor.
Hypertrophic bromide.
Yeah. I think
Case 5.
I think that's all we really need in this scenario. So 38-year-old female. So she had presented new onset bilateral nasal drainage, headaches. She seemed to be worsened by straining. But interestingly enough, this is a patient who came back positive for beta 2 just from right-sided nasal drainage. However, she swore to me up and down that she was having bilateral nasal drainage. It was coming from both sides, but she couldn't collect it for whatever reason from the left side. And so, this is a patient, we ended up getting a CT scan first, and until we got the CT scan, it showed me a little bit concerning findings. And so we see here kind of it's identifying bilateral defects involving the lateral recess of the sphenoid. pretty far lateral, almost extending onto the most lateral aspect of the floor of the middle fossa. Especially on the right side, we see a lot of pooling of secretions here. What we think is secretions, maybe encephalocele, but interestingly enough, patient also had a contralateral left-sided defect, again, extending onto that almost the floor of the middle fossa, lateral to the eminence of the infraorbital nerve. So obvious defects here. There seems to be pooling of secretions. And so this scenario, because I couldn't really get a sense for, is there an encephalocele? Is there herniated brain contents? And based on the CT scan, seeing the soft tissue definition, I opted to get an MRI also. And the MRI findings were more particularly concerning because now we're seeing basically a large encephalocele bilaterally, worse on the right than it is on the left, herniating through that bony defect with involving cerebrospinal fluid, which is actually pooling in the sphenoid here. But I really kind of draw your attention here. There's a significant area of encephalocele really far lateral, essentially a couple centimeters or a couple millimeters off of the midline. And so surgically here, is this, when we're thinking about our approach here, standard approach, we would think an endoscopic transnasal approach to be able to get to these leaks, but this was a very different defect here, and I'd like to kind of solicit your thoughts on how would you approach these scenarios where we're seeing a defect that's essentially extending out into the lateral aspect of the middle fossa. And then in this scenario, two questions here. We'll think about, is this something that you would address both areas at the same time if they're both actively leaking? Would this be something that you would address the primary defect, which seems to be herniating from the right side? And then do you think this is something that can be accomplished entirely endoscopic? What are your thoughts here?
Yeah, this is a really tough case. I can't say that I've actually encountered anything quite like this before. So I think I'll take a stab at it. I mean, I think that someone is going to be having an encephalocele in both lateral recesses if they are in a high pressure situation. And so, I think that's our kind of primary guess as to, what's driving this process. So we have all of the same concerns that we've previously mentioned. I think with respect to, the approach, particularly the defect on the right, not only is it lateral, but it's also, pretty narrow. You can see that angle is really narrowing there. In lateral recess sphenoid encephaloceles, we'll typically do a transpterygoid approach, often in a nostril, and can be pretty successful with utilizing that. I don't think this is going to be able to be repaired with just a single nostril, at least I think in my hands. I think you could give some consideration to using both nostrils and doing a posterior septectomy and potentially getting that far lateral. But even then, I think it's going to be a real challenge, kind of getting out there. And then, but I think, patients, when presented with an open approach versus an endoscopic approach, the morbidity of our endoscopic approaches is generally fairly limited. I think it's not zero, but I think it's limited. And I think I don't think it would be wrong to attempt it here while, giving full disclosure of the potential limitations of what we can do endoscopically. But I think for me, this would require, certainly something augmenting our traditional transnasal approach. And you've made mention of, Vidian and V2 are certainly, at risk there, and you have to talk to the patient about potential injury to those.
Yeah, and we'll kind of go through that in a second here, but you're being too honest because I know you've handled definitely worse than this and significantly more complex.
I do think I would try both defects though at the same time.
That's and then I would point.
And I do think I would try to handle both defects, and I think I would, maybe this is again a chance to utilize a lumbar drain, but also, maybe talking about, we didn't really talk about shunts today, but again, management of the pressure is going to ultimately drive our success here. So
yeah. Absolutely.
So what'd you do?
So we'll go into the nitty gritty. So thinking I'm a cowboy, we'll try the uninostril. I think like you, Dr. Rangarajan, we got it less invasive. I trust my surgical technique. I trust my hands. I mean, we should always try something less morbid, right? So this is the exposure of the transpterygoid, as you had mentioned, the exposure of the PPF contents and sphenopalatine artery. I know people have published on the transpterygoid approach without sacrificing the sphenopalatine. In the East scenario, I think it was needed because of the exposure. I just want to pause the video here. This is the quintessential bone that needs to be removed, right? So this is the exposure of the pterygoid wedge, kind of the juncture of that lateral wall of the sphenoid and floor of the sphenoid. That's that bony window between the foramen rotundum and then the Vidian canal. As we can see here, we're actually retracting the fascia of the PPF, the pterygopalatine fossa. And really, there's a big limitation here. And so we think about our traditional transpterygoid approach or modified transpterygoid approaches. We try and spare the vidia nerve just because of the related morbidity with sacrificing it and the potential for dry eye. But in this scenario, just by retracting the contents and drilling this bone, I can't even visualize where the encephalocele is coming from. And so in this scenario, I actually ended up resecting and transecting the vidia nerve in that scenario for the reason of exposure. And so you'll see here in a second, so I essentially cut the vidia nerve. I'll then cauterize kind of the base of it. There's actually an artery that travels with that vidia nerves, as you know. And so by doing so, we're now starting to get more lateral. We're dissecting directly into an exposure of that middle fossa endoscopically. Still here uninostril, still here single-sided. But now when I expose and retract that pterygopalatine fossa contents, I can get more lateral. And now we're finally starting to see that head of that encephalocele. And so this is actually with a 45-degree scope. This is the visualization of that lateral sphenoid encephalocele herniating from that defect, trying to mobilize that contents, just like we mentioned in that other prior case of the sphenoid encephalocele along the sphenoid planum. But this is now with a angled suction, uninostril. We're visualizing with a 45-degree scope, and I still am not able to get to where that defect is coming from. And so in this scenario, kind of in the interest of time, we'll kind of just go over here. But, as you mentioned, a traditional approach here is really not going to get you to where you need to be. You're not going to be able to visualize that bony defect. You have an angled instrument. I have an angled malleable suction cautery here, and I still can't get my window around because of the bony trajectory. And so in this scenario, what would you do in these scenarios to really help you with that lateral reach? I think we can talk about, doing a more direct approach, whether or not you do a Colbo-Luck or an anterior maxillotomy to be able to get access versus our traditional septectomy and be able to come from the contralateral side to be able to get access to there. Is there anything that you would do specifically? I mean, I think at this point, you and I might agree that the septectomy would probably get you the best access. Do you think there's any way that you could, spare the vidian in this scenario? Any other thoughts on kind of how you would improve your surgical exposure?
I think in this case, I would have also taken the vidian and the sphenopalatine artery. I think my reflection of that video is that your visualization wasn't bad. I mean, it was almost there, but your instruments were really suffering. And so because of that reason, I think for me, I would have gone to a posterior septectomy and created a binarial approach because I would be able to get my instruments in at an angle. Now, the thing is that we're not in the sphenoid, right? Or we're not in the sella, right? We're not like in the midline. So my concern is like, how big of a septectomy would you need in order to get the instruments over to that side? I think, again, you kind of get a sense of these things when you're kind of feeling the tissues and seeing like, where am I getting hung up? But I think that that's what I would do in that situation. I thought that your bony resection was otherwise pretty good.
Yeah, so that's great. All great points. I mean, in this scenario, and we'll kind of go over this, because I actually decided to address the contralateral encephalocele, it was kind of a no-brainer to be able to do septectomy, address the contralateral side. You bring up a very good point in that you can do a septectomy, but you're not in the midline, and so unfortunately or fortunately, we can resect the septum pretty far anteriorly, as long as we keep maintaining some of that anterior L strut as we would do during a septoplasty. And so that actually enabled me to get access. But, this goes back to the original question, right, is that, take this 10, 12 years prior, right? Fat probably would have worked great in this scenario. And so, I thoroughly thought to myself, do I need to get to that bony defect? Am I physically able to get to that bony defect? And I brought in one of my senior partners here because this is a location that was more lateral than, like you had mentioned, it's not commonly seen. And so we'll kind of go through here with this exposure, but, a pretty wide septectomy here. I'm actually just harvesting a mucosal graft off of the septum. Unfortunately, I'm sacking bilateral sphenopalatine arteries and thereby kind of obviating my ability to use the nasal septal flap if I need it in the reconstruction. But here we're again exposing the same area, the pterygoid wedge, lateral sphenoid. This is the contralateral encephalocele. In this scenario, I actually opted to spare the vidian just because I knew that I was sacrificing the contralateral side. But in this scenario, fortunately, the contralateral encephalocele was more midline area in the lateral, the sphenoid roof. Coblator worked great here. We're able to visualize kind of a blade back to the defect kind of in standard fashion. And so a much more obvious area and location. And as we'll kind of see here, once we start to work through the binostril approach, this is actually with a 70-degree scope. And so, we're looking at that defect. I'm able to visualize it. At this point, I'm just curious to get your thoughts on here. When we visualize that defect up to that point, stopping here, how would you approach this? Because I really kind of had a little bit of a difficulty in addressing how I would go to this at this stage. I've essentially ablated the back to the defect. I've stopped the leak essentially with cautery at this point. I had a thought to myself is, do I need to resect that extradural tissue? And you'll see in a second that I opt to resect that extradural tissue because you and I have been, harbinger or ingrained into us that we must get back to that bony defect. We must visualize that bony dural defect because that's how you get the tightest repair. That's how you're going to get your reconstruction to sit. But, in this scenario, especially with so far lateral, could you opt to use fat to essentially plug this defect and essentially obliterate that space and maybe cover in mucosal graft? But what are your thoughts there on how you would further go about this?
Yeah, I mean, I think I would still try to take it to the bony defect. Obviously, like you said, they're not leaking. You've kind of taken care of most of the problem. You're right. Fat can work here. I think, and if I were utilizing fat, I'd put fat and then some type of surge cell or something like that to kind of tame the fat. And again, do a robust multi-layer closure. There's nothing wrong with fat at all. Then one of the disadvantages is that if you do post-op imaging, there's always going to be something there, and you're never going to be certain if, how much of it is encephalocele and how much of it is your reconstruction. But I think you've done a really, really nice job. There's going to be, we knew this at the start of this case, that there's going to be an extent at which, potentially our endoscopic approach is not going to be enough.
Yeah.
But I certainly think fat would be reasonable here.
So see,
but you have to do something.
This is why we always think alike, though, because I opted to do exactly what you said, and you haven't seen this case before, right? So it's like magic that you are just exactly narrating what's going to happen next. But so. This is a cross-core technique. I'm in the contralateral nostril with endoscopic bipolar here in this scenario. To your point, I still wanted to try to get as much of that tissue out as possible. I'm actually resecting a part of that mucosa and extradural tissue in this scenario. This is a frontal grasping instruments through the contralateral nostril to be able to get the angle. Again, this is a 70-degree scope. We're now finally back, I think, close to the defect, but basically as comfortable as I think I can get back to that defect. And so just like you had mentioned, Surgicel and fat, honestly, this was a tip and trick from one of my senior colleagues that worked like a charm. I was able to use a half-by-half pledget to basically almost dumbbell the fat into the defect. And for complete closure sake, I then used a mucosal graft in that area, essentially thoroughly cover that region and essentially close that space off. And so the important part here is when you're doing something like this, like a multi-layered closure with fat followed by mucosal graft, is that ensuring that you're getting all the mucosa out. Because to your point, if they were to develop a mucocele on imaging, it'll be very difficult to really assess if they're a recurrent encephalocele or not. I think all of these cases really showed different approaches, different techniques on how we approach encephalocele and CSF leak management. These are all diagnostic challenges. They're interventional challenges. Any, pearls of wisdom from your experience? You've done this plus a handful of others. Next time we're on here, I'm going to have you, just completely destroy me with challenging cases, challenging defects. Maybe we'll do sinonasal tumors next time.
Yeah.
But any thoughts on take-home points, pearls of wisdom when you think about what your algorithm is when you approach these challenging CSF leak patients?
Yeah, I mean, I think having an algorithm of some sort is important. I think there's always institutional differences in, kind of how we approach these patients. I really do believe there can be, more than one right answer with our approach to these patients, particularly with techniques. But I do believe that being meticulous and thoughtful with reconstruction, and then also just taking into consideration the overall disease process and managing, the underlying reasons for why they arrived in this situation, are really going to be the most important things for success. Again, I kind of flippantly mentioned it earlier, but you can't expect to throw a bunch of stuff out there that you get off the shelf and expect that it's going to work. I think you really have to understand the location and the geometry of these defects. Pick the appropriate, whatever appropriate means to you, pick the appropriate materials, plan for whatever grafts you're going to use, and then do your work meticulously. It sounds like common sense, but I think sometimes people are surprised when, you just, throw some dural sealant or something and expect it to work and it's not going to work. So I think that's my biggest pearl. I think it's okay we all have a few differences here and there.
Yeah. Excellent. Well, thank you so much.
Yeah, thanks. This was fun.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe Legrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening and see you next week.